Hello, everyone. We'll get started shortly. Welcome. I'm Maggie Nicholas Alexander, the Senior Director of Gynecologic Cancer, Patient Support, and Education at SHARE. I'm so glad you joined us for today's webinar, Coping with Early Menopause After Gynecologic Cancer. Before we begin, I'd like to tell you a little bit about SHARE. We're a national nonprofit dedicated to education and support to anyone affected by breast or gynecologic cancer, as well as community outreach. We recognize that cancer affects every community, so our programs are inclusive and welcoming to individuals of all races, ethnicities, ages, gender identities, sexual orientations, and backgrounds. In addition to webinars like this, we offer support groups, support lines, outreach, navigation, and other free programs and resources. You can learn more by visiting our website at sharecancersupport.org. At SHARE, we believe no one should face cancer alone. Before we dive in, a few quick reminders. All participants will be muted during the presentation. After the presentation, we'll have a Q&A session. You can submit questions at any time using the Q&A box located at the bottom of your screen. Please remember our speakers cannot give specific medical advice, so keep your questions general. Closed captioning is available. Click the live transcript button at the bottom of your screen to enable subtitles. This webinar is being recorded and streamed to YouTube Live. The link to the recording will be available right after the webinar on SHARE's YouTube channel. Now, I'm excited to welcome our speakers, Dr. Gerber and Dr. Frey. The screen is yours.
Hi, I am Deanna Gerber. I am a gynecologic oncologist at New York Presbyterian Weill Cornell. I work with Dr. Frey. What I do is I specialize in care of women with gynecologic cancer. I also treat survivorship issues that women may have, including menopause, and also work in prevention of gynecologic cancers. Personally, I'm also a breast cancer survivor, and I have a BRCA1 mutation, which is why survivorship care holds a very special place in my heart. I'll pass it over to Dr. Frey.
Hello, my name is Melissa Frey, and I am also a gynecologic oncologist at Weill Cornell Medicine, in addition to being the director of our genetics and personalized cancer prevention program. And so I'm very interested in gynecologic cancer, but also interested in thinking about the whole patient. And so with genetics, that's thinking about every cancer that someone's at risk for, but also as someone who sort of sees people throughout a lifespan, realizing that there are many things that come up after a cancer related to quality of life and long-term health. And so I'm so happy to be able to talk about that and talk about sort of menopause and long-term health today. So I think with that, we're going to get started with our slides. Great. So we have three main topics. The first will be a quick overview of gynecologic cancer. Then we'll talk about a quick overview of menopause. And finally, I think the most important part of this talk by Dr. Gerber, which is menopause management options for gynecologic cancer patients. So to start with ovarian cancer, we know several cases each year, and unfortunately several cancer deaths. What are the risk factors for ovarian cancer? Older age, several genetic factors, and then also reproductive risk factors like early menarche, late menopause, endometriosis, polycystic ovarian syndrome. Some of the signs and symptoms, I think this is one of the most difficult parts about ovarian cancer is that, often the signs and symptoms are not felt until there is advanced disease. So abdominal or pelvic bloating or pain, often because disease has spread outside of the ovary. What we call early satiety, which is where you kind of feel quick, gastrointestinal symptoms, urinary symptoms, or other sort of vague symptoms like fatigue or low energy or weight changes. And how do we treat ovarian cancer? So in general, treatment is surgery, and we surgically remove the ovaries, uterus, cervix, and fallopian tubes, and then often having to combine that with chemotherapy and other targeted therapies for personalized care. And we know some of the greatest challenges in ovarian cancer are early detection. We have yet to identify an effective screening tool that can find ovarian cancer at its earliest stage or even at a precancerous stage. And so that is something that many groups are working on, and hopefully this slide will look different a few years from now and we will have better screening. What about uterine cancer? So, many more cases of uterine cancer. It's actually the most common of the gynecologic cancers, and the number seems to be growing with over 60,000 cases each year. Sort of what are the contributing and protective factors? So things that protect against uterine cancer: oral contraceptives, IUDs, multiple pregnancies, and physical activity. And what are the risk factors? There are hormonal and reproductive risk factors. So unopposed estrogen, so having lots of exposure to estrogen, either because of obesity, because we know that adipose or fatty tissue in the body makes estrogen, or taking unopposed estrogen, like in a hormone replacement therapy. Early, having your period early or going through menopause late, having infertility or cycles that are not normal ovulatory cycles. And so individuals with polycystic ovarian syndrome or PCOS are at increased risk for this. And there are several metabolic or lifestyle risk factors. So obesity, diabetes, hypertension, overall metabolic syndrome, and physical inactivity. And then, although we usually think of ovarian cancer as really the genetically driven gynecologic cancer, we do know that there are some genetic mutations that can increase the risk of uterine cancer. So Lynch syndrome, Cowden syndrome, or PTEN, maybe even BRCA1 has been linked to some aggressive forms of uterine cancer. And then also certain medications like long-term tamoxifen use. Tamoxifen is a drug that's often used for breast cancer, but can also cause a cancer in the uterus. What are signs and symptoms of uterine cancer? Well, unlike ovarian cancer, there actually is a symptom that people notice quickly or early in the disease, which is a good thing because we can often find uterine cancers at an early stage, and this is abnormal uterine bleeding. So for someone who has not had menopause yet, for someone who gets normal periods, this could be heavier bleeding or bleeding between periods or bleeding in between a cycle. For someone who's already gone through menopause, this often presents as postmenopausal bleeding, or for someone who has not had a period in a long time, suddenly having bleeding. What are some of the symptoms, other symptoms? Pain, pressure, pain with intercourse called dyspareunia. Some people can have pain with urination or pain with using the bathroom. And sometimes if the uterus is really big, people can actually notice a mass in their belly. What are the treatments? Well, quite similar to ovarian cancer, the treatment is to surgically remove the uterus, cervix, tubes, and ovaries. So again, we're taking out the ovaries, making hormones. We are causing menopause in people who have not yet been through menopause. In addition to that, depending on the stage of uterine cancer and what it looks like under the microscope, we do sometimes have to use radiation, chemotherapy, and other targeted therapies for personalized management. And then finally, cervical cancer. And so one of the least common cancers of the gynecologic cancers, at least in the United States. So there are only about 13,000 new cases each year. What are the risk factors? Well, we know really that the most important risk factor is an HPV infection. And HPV tends to be, a sexually transmitted infection. So there are many sexual or reproductive sort of risk factors. So early onset of kind of first sexual activity, having multiple partners, having a history of sexually transmitted infections like chlamydia or HIV. We also know that anyone who has immune suppression, like any other illness or medications, that reduce immune function can increase the risk of cervical cancer. So this could be HIV. This could be any individual who's needed a transplant, like a kidney transplant or any organ transplant, because those individuals often have to be on immune suppressing medications. Also some lifestyle factors. So smoking, certainly sort of exposure to smoking increases the risk of cervical cancer. And then also reduced access to screening and vaccination, because we know actually we have great tools now for screening, and that's a pap test looking at like the cells of the cervix and also looking for HPV. And we have vaccination with HPV vaccines, which are quite effective, although still kind of sadly critically underutilized. How do we treat cervical cancer? So surgery involves generally, it's in early stage, we can remove just part of the cervix, but for more advanced stages, we are removing, again, the cervix, the uterus, the ovaries, the fallopian tubes. Depending again on the stage, we sometimes have to use radiation or chemotherapy. And there are also targeted therapies that are working quite well in cervical cancer. And then also a big push for HPV vaccination. So anytime I'm in any group, I always say this, remind the people in your life to get HPV vaccines. This is for men and women, and it's something that everyone should consider. So what are the side effects from gynecologic cancer treatment? So common side effects, which can be from surgery, can be from chemo, can be from radiation, can be from just having a cancer diagnosis, fatigue, pain, sexual dysfunction, emotional and psychological impact, of course, from having this diagnosis. And then, of course, fertility concerns, right? We are taking out the organs that are needed for fertility. We're taking out the ovaries, which are needed to make oocytes, the tubes, which are needed to have oocytes find their way to the uterus and meet up with sperm to get fertilized, and then the uterus, which is the organ that is needed to carry a pregnancy. So now we're going to switch to menopause, because I think I sort of told you all of the difficult parts about having a gynecologic cancer, which is not just, of course, dealing with the cancer, but also recovering from the surgery. And so there's this kind of moment where it's the diagnosis of gynecologic cancer, then usually the surgery, which we embrace because we want every woman to have a cure. So removing the uterus, ovaries, and fallopian tubes, often giving chemotherapy or radiation. But then we have to remember, kind of at the other end of this arrow is menopause. And certainly for someone who is not already in menopause, this is going to cause menopause. Once the ovaries are out, that's menopause. But even in the cases where we don't take the ovaries out, the chemotherapy will often cause menopause. And so what are symptoms of menopause? So we start with what's called vasomotor symptoms. These can be hot flashes, which is a sudden feeling of heat in one's face, neck, or chest, or night sweats, which are kind of hot flashes during your sleep that often cause people to wake up. And I think when people who haven't been through this yet hear this, they would say, oh, okay, but so you're hot, that's not that big a deal. And I think that really that means that someone has not been through this, because these can be life altering, not being able to have sleep. And so chronically being, not resting, people being worried about at work, giving a presentation or being in a group and suddenly having a hot flash. This really can be debilitating. And so I think it's important that we take these symptoms seriously. There are also genitourinary symptoms. So vaginal dryness, which can cause pain with intercourse or make intercourse or sex impossible for some individuals. Recurrent urinary tract infections, new urinary complaints. So someone who may have had no trouble controlling their bladder or their urine beforehand suddenly is having to go to the bathroom several times a night, or even not able to make it to the bathroom in time, or having leaking urine with coughing or sneezing. And then finally, sleep and cognitive symptoms. So apart from even having hot flashes in the middle of the night that wake someone up, there can just be insomnia from loss of hormones, or some people just cannot fall asleep, or they can fall asleep well, but then chronically are waking up in the middle of the night. And probably related to this, but also just a general complaint, independent of sleep complaints, is memory changes or kind of difficulty concentrating. And you'll hear many women talk about the idea of brain fog from menopause. And also this happens with chemotherapy, but certainly even without chemotherapy, just from the loss of hormones. mood and emotional symptoms. And so suddenly someone who has had like very stable mood can find that their mood is changing, rapidly, or they're more irritable or more anxious or more depressed than usual. And the only thing that has really changed is menopause. We can also see weight changes. And so some people can have weight gain, or some people don't even gain weight, but they just notice that their weight is redistributed. So suddenly there's people are kind of holding on to weight more centrally or around their kind of center abdominal area. People can have joint or muscle aches, skin, hair changes, which are often kind of thinning or drying of the hair. And then, so I kind of described, like, I think I just gave a 2-page, 2-slide summary of all the problems with quality of life and with day-to-day life. But that's not even thinking about what are the long-term health outcomes. And so we know that having early menopause, which we kind of define as sort of having that menopause brought on suddenly by either surgery or by chemotherapy or radiation, is not good for bone health. And so people are at critically increased risks of having what's called osteoporosis or low bone density, which then puts people at risk for fractures, hip fractures, arm fractures, just overall sort of having less strength in one's bones. It's also not good for heart health or cardiac health. So we know that having early menopause increases the risk of having sort of bad heart outcomes later in life. And then, not surprisingly, also neurologic health. We know that people report almost immediate brain fog or memory changes, but we also know that long-term Alzheimer's, dementia, Parkinsonism also seem to be more common in individuals who have early menopause.
And so now I can share just the menopause management options for gynecologic cancer patients. So when we think about why this is important, I know Dr. Frey talked a lot about this previously. We as oncologists, we propose a treatment plan for our patient that will leave a patient in menopause for whatever reason. And that can be an acceptable outcome for a lot of people if the cancer is cured or if the cancer is less likely to come back. But comprehensive survivorship care involves a good assessment of quality of life considerations. The symptoms of menopause can be debilitating, as Dr. Frey mentioned, and these overlap quite often with the negative effects of being a cancer survivor in general. And so there's physical symptoms like the hot flashes, the vaginal dryness, the insomnia, and the fatigue. And then there's the anxiety and depression and body image issues, which are all really common in cancer survivors who aren't going into menopause, but can be doubly as terrible with menopause. Not to mention the sexual health outcomes like decreased libido, painful intercourse, strain on the relationship that can cause, or by being a cancer survivor can cause. And then also we're having people return to work, fill their normal roles in society, their normal familial roles and normal social interactions, which can be really altered with menopause and with cancer survivorship. Clinical guidelines from organizations such as NAMS, which is the North American Menopause Society, and ACOG, which is the American College of Obstetrics and Gynecology, provide guidelines that kind of emphasize individual care and the importance of making these multidisciplinary plans for women who are undergoing cancer survivorship and menopause as well. A multidisciplinary approach, including different care providers such as gynecologists, medical oncologists, your primary care doctors, and mental health experts, when used together, can improve quality of care and continuity of care. There should be regular meetings and shared records through the electronic medical record system to facilitate effective communication and patient-centered decisions. And what we know is that by including patients in this collaboration and having people be part of their care, this leads to more clear guidance, and this is empowering for the women on their healthcare journey. And so these survivorship care plans should be multidisciplinary, meaning many different teams involved, and the patient or the woman with the symptoms should be kind of at the center of that team. So lifestyle modifications play a crucial role in the non-hormonal management of menopause. There are several different interventions that have been shown to be effective in menopause management. Regular activity, such as regular exercise, has been shown to reduce the frequency and severity of hot flashes. Also, exercise has been shown to improve mood and enhance sleep quality during menopause. And this is in cancer survivors and not cancer survivors as well. We also know that healthy diet is important. A balanced diet with fruits, vegetables, and whole grains is important, but also a diet high in vitamin D and calcium is important for bone health. Physical activity is also very important for bone health. So strength training can also improve bone health, which is a known side effect of menopause. And then there's techniques that have been shown to be scientifically, significant in managing menopause, such as yoga, meditation, acupuncture, and Tai Chi. These have shown to reduce the severity of menopausal symptoms and reduce stress during menopause. Other lifestyle interventions that I frequently will recommend to patients is improving sleep hygiene. So making sure that your patterns before bed are good. So avoiding screen times before bed, making sure you're doing calming things before bed, getting in bed before you actually want to be asleep. That can improve your ability to stay asleep. Avoiding caffeine before bed, which is less likely to have sleep disturbances and whatnot. Oh, this got weird. So there are also complementary and integrative therapies that offer holistic approaches to managing menopause symptoms, which can be used alongside of conventional treatments to enhance well-being. Acupuncture has gained a lot of popularity lately for its potential to reduce hot flashes and improve sleep quality, with some studies suggesting that that there's also beneficial effects on vascular health in general. Herbal supplements such as black cohosh and red clover have been shown to also be effective in treatment of vasomotor symptoms like hot flashes. Though the benefits in different studies does vary, they have been shown to have some benefit. Cognitive behavioral therapy, or CBT, is a kind of therapy that focuses on one symptom and helps minimize the symptom, the effect that symptom has in your life, and that's been shown to improve hot flashes and vasomotor symptoms as well. And then there's also other mindfulness techniques, mindfulness-based therapies that include yoga, therapy, and other modalities that have also been shown to reduce the severity of menopausal symptoms. These therapies all highlight that a patient-centered approach, talking to the patient about what their symptom is and what their desire is, to what kind of medications or what kind of modalities to use, will be beneficial. And of course, education and shared decision making is vital to any menopause management strategy. So understanding patient preferences is essential in selecting the appropriate non-hormonal therapies. Many women prefer lifestyle and behavioral interventions due to their safety and holistic benefits. Complementary therapies are also likely to appeal to patients seeking natural remedies, though, as doctors, and medical team, we're gonna, discuss the benefits and the data behind these modalities. But then there's a lot of women who prefer pharmacologic. And so you see here that 40% of women will actually prefer pharmacologic. And so that's where, we'll focus the next bit. When it comes to pharmacologic interventions, there's one main question that we get asked as oncologists, and it's to use hormones or to not. And as you can see here, there are several different medications that can be used in the treatment of menopausal symptoms. On the left here, you see the non-hormonal options. We'll go into all of these more in depth on the coming slides. And on the right here, you see all the hormonal options. You see that there's different classes of medications, different routes of medication, different ways to dose the medication. But why is use of hormones in gynecologic cancer survivors a controversy? So I just want to talk a little bit about the science behind the question, which I think is why many of you probably joined this talk today. So this concept was discussed in a 2024 Lancet paper. The Lancet is a very reputable medical journal that in 2024 came out with a menopause series because they want to kind of discuss the issues regarding menopause. And so as part of their menopause series, they put out this paper called Managing Menopause After Cancer. And the hope was that medical providers could have a more scientific approach to why it's an issue and how we can manage the issue. And so we could talk about breast cancer for a second. So breast cancer, when people talk about it, it's very commonly talked about as hormone positive or hormone receptor positive or triple negative. And these are terms that we talk about a lot with breast cancer. We don't talk about this a lot with other cancers. What hormone receptor positive means is that the cancer or the tumor on its surface has receptors that if there's extra estrogen or extra progesterone, it'll link to that receptor and cause growth of the tumor. And so, you know, when people say they have HR positive breast cancer or hormone receptor positive breast cancer, it means that estrogen actually causes the tumor to grow. And so avoiding estrogen is advised. When it comes to the gynecologic organs, which is what we'll focus on today, the uterus, the gynecologic organs in general have hormone receptors on them, as one would imagine. Gynecologic organs are meant to respond to hormones when they're working well and without cancer. What we know about cervical cancer is that not many hormone receptors noted with this, and that's same for vulvar and vaginal cancers. Uterine cancers tend to be hormone receptor positive and ovarian cancers don't, but I'll talk a little bit in depth about each cancer now. So endometrial cancer is technically considered a hormone receptor positive cancer. The overwhelming majority of endometrial cancers will be hormone receptor positive, meaning ER and PR positive. ER is estrogen receptor, PR is progesterone receptors. And so this influences our ability to give hormones after cancer care. Or it makes you think that it makes you stop and pause to think, is it the right time to give hormones? And what we know is that, you know, hormones can be safe. So anti-hormones are often used in treatment of endometrial cancer. As Dr. Frey talked about before, endometrial cancer treatment will put most people into menopause. It's the number of endometrial cancer cases in our country are growing, and that's likely related to a lot of environmental factors and the rising rates of obesity in our country. And with that, we're seeing rates of endometrial cancer in younger women increasing as well. And so younger women getting cancer before menopause is what we're seeing a lot. And while sometimes we can preserve hormonal function, we can leave ovaries, very often endometrial cancer care will not leave the ovaries, and so will put you into menopause. And so this is obviously a field, an emerging field where there's a lot of questions because putting young women to menopause is not something that us as oncologists take lightly. It's something that we very much, contemplate and want to be thoughtful if and when we're doing that. And so there are a few studies that have shown that hormone replacement in women who are in menopause due to endometrial cancer is actually safe. So in early stage, low risk histologies, which is a big majority of endometrial cancer, hormone replacement is actually safe to use. And as always, we want to make sure we're being very thoughtful about which patient or which woman we're putting on HRT. And again, I'll say this a million more times today, the treatment decision should be very individualized. It should be a discussion based on your individual symptoms as the patient. So what symptoms are you looking to mitigate? How severe is your symptom? And talking with your oncologist about the risk. So when we now switch to ovarian cancer, there are ovarian cancers that are hormone receptor positive, so are sensitive, would be sensitive to hormone receptors, but the majority of ovarian cancers are not hormone receptor positive, which allows for us to safely consider estrogen replacement therapy or hormone replacement therapy. As one would, guess, ovarian cancer treatment does require usually removal of both ovaries to prevent, the cancer occurring on the other side or reduce the risk of recurrence. And so again, we're putting women into menopause. And so again, we want to be thoughtful about when and whom to give hormone replacement to, because we don't want to leave young women with these debilitating quality of life issues or issues that'll, like an osteoporosis, that'll affect them in the future. So there is also similarly studies in ovarian cancer that have shown that hormone replacement therapy in ovarian cancer survivors has not been shown to worsen the survival rates or the efficacy of treatment. And so recurrence rates have never been shown to be higher with hormone replacement. And so that leads us to believe that hormone replacement therapy in ovarian cancer is safe. And again, we know that there's a multitude of benefits of hormone replacement therapy. And so it's definitely something that, our current guidelines in the Society of Gynecologic Cancer say that it is safe to use hormone replacements in ovarian cancer survivors. And again, we want to manage the symptom and the benefit and the safety always. And then when we think about cervical cancer and hormones, the overwhelming majority of cervical cancers are not hormone dependent. As Dr. Frey mentioned, their cervical tissue is not really hormone responsive, and the majority are related to HPV. And so we think of cervical cancer as a relatively safe time to be able to give hormone replacement. With cervical cancer, so with endometrial cancer and ovarian cancer, we're removing the ovaries. So we're putting people into surgical menopause. That's not always the case with cervical cancer. Oftentimes, we don't do surgery for a locally advanced cervical cancer, but we'll then recommend radiation. And even if your ovaries are moved out of the radiation field, there's a big chance that the radiation will still affect the ovaries and cause the ovaries to go into menopause by kind of affecting the blood flow to the ovaries. So menopause is a consideration in cervical cancer, even without surgically removing the ovaries. And so when we think of, so I have patients ask me all the time, like, do I need hormone replacement therapy? And the answer is no one needs really hormone replacement therapy, but there's a lot of people who are candidates for it, and it should be considered for them. So what are the indications for hormone replacement therapy? Number one is hot flashes. Along with that comes night sweats. And then we have the genitourinary symptoms of menopause, the vaginal atrophy symptoms. Poor sleep is an indication. Mood changes, mood swings. And also consideration for hormone replacement to prevent bone loss, prevent osteoporosis, and to treat women who, go into very, very premature menopause. So premature hypogonadism is the term for that. So there are several different ways to give hormone replacement or HRT. It can be given systemically, so it can be given in a pill format or in a patch so that it's going throughout the body, or systemically, or it can be given locally with like a topical cream for whatever tissue you're using, you want to use it on. Traditionally, patches are preferred because there are less risks of blood clots, of venous thromboembolism. And so venous thromboembolism is one of the main reasons why many years ago hormone replacement therapy was kind of villainized, why it kind of went out of out of fad, because people were scared of blood clots, along with many other symptoms. And so the patch can kind of mitigate that risk as well. And so again, risk stratification is important. So a discussion of the symptom, the severity of the symptom, the impact it has on your life, and the proposed benefit versus risk of using a hormone replacement is absolutely something we need to always be considering. And again, there are guidelines that SGO, the Society for Gynecologic Oncology, and ACOG provide to help kind of discuss these things with the survivors that we treat, and will help with shared decision making. And of course, we want to take in consideration what kind of cancer, age, and the symptoms. And then there are other non-hormonal options. So despite, the past few slides talking about how hormones are safe in certain cancers, there are certain cancers in which hormones are not advised, or not even not advised. There isn't any data to say that we can or can't. And so oftentimes in cancer care, we like to hedge on well, maybe we shouldn't. And that's, a valid reason to not, if there's not any data to say it's bad or it's good. And so a lot of women will prefer a non-hormonal pharmacologic agent. One of the main classes of medications that's beneficial in reducing vasomotor symptoms or hot flashes are SSRIs or SNRIs. These are the selective serotonin reuptake inhibitors, or selective the SNRIs, which are the class of antidepressant medications, which have a good benefit on vasomotor symptoms and also help with mood swings as well. So they have like a dual purpose. We use a lot of these antidepressants off-label, but paroxetine, which is Paxil, is actually FDA approved for the treatment of hot flashes. Side effects of this can cause sexual dysfunction, bloating, headaches, and so it's definitely something to discuss with your doctor. Another medication is called gabapentin. It's a neurotropic medication. It's a nerve medication, which also has been shown to help with hot flashes. Tend to use at night because gabapentin can make you a little kind of loopy, a little groggy. And so, it could also help you, if you're groggy, it could help you sleep a little better. And so it's used at night. Clonidine is a blood pressure medicine that has also been shown to have benefit in treatment of hot flashes, and that can also be used. On the next slide, I'll show you the efficacy for all of these. And aspemifene is a SERM. It's a selective estrogen receptor modulator that has been shown to help with painful sex or dyspareunia, which it acts on the estrogen receptors in the vagina without affecting the estrogen receptors in the uterus or the breast. And so it's relatively safe and can help with vaginal symptoms. And so these medications have a good symptom reduction profile. So the SSRIs and SNRIs have 40% reduction in symptoms. That's good. Hormone replacement has a much higher reduction in symptoms, but again, it's a personalized decision and not safe in everyone. Gabapentin has a 35% symptom reduction, and clonidine at 25%. One new medication that I really want to bring attention to is something called Veozah. It is a first-in-class medication. It has a new concept. So there's this neurokinin 3 receptor that exists in the brain that help regulate temperature and heat and whatnot. It's like the internal thermostat. And so this Veozah can block that receptor and can kind of help your brain regulate its thermoregulation. So your thermostat can kind of be a little bit less erratic and less vasomotor symptoms, less hot flashes can be seen. And so this was FDA approved in 2023. Tends to be very expensive, but it's very efficacious. It works really well and doesn't have a lot of long-term side effects because it leaves your system relatively quickly. There are some big side effects that we need to monitor. It can affect your liver enzymes. It has a black box warning for potential for liver enzymes or liver damage. Can also cause abdominal pain, diarrhea, and insomnia. And so with this medication, you want to make sure that you are having your liver enzymes tested. And a lot of times insurance companies will approve it if we can document why hormone replacement is not advised in your specific situation. And so that the medical team will need to document it well to get it approved by insurance. Though I have been seeing lately that it's getting approved a little bit more easily. So what about vaginal symptoms? When you look at this table, this is from the same paper we talked about from the Lancet a few slides ago. When you look at the left here, the vasomotor symptoms here, and all the medications and interventions we have, the SSRIs and SNRIs are very likely to help with vasomotor symptoms. The gabapentins, the clonidines, the CBT, the cognitive behavioral therapy is likely to help with that. And yoga and mindfulness is possibly to help with that. But then when you look at the other two columns, the sexual dysfunction and the vaginal dryness column, you see the word unlikely very often, meaning that these interventions that we've talked about in the last several slides are unlikely to help with these two big symptoms, sexual dysfunction and vaginal dryness. And so what can we be doing about that? So there are several comprehensive approaches to vaginal symptoms. So there's several lifestyle modifications that have been shown to help. So regular sexual activity and pelvic floor exercises have been shown to help vaginal health and elasticity. So can help the body kind of prevent from becoming restructured with the loss of the estrogen. The tissue in the vagina and the vulva are very responsive to estrogen. And with menopause, with the withdrawal of estrogen, the tissue can become less plump, less plush. And so kind of using those organs more commonly can help you avoid those changes. There are also several non-hormonal treatments, such as moisturizers and lubricants. There's a lot of lubricants that use hyaluronic acid, which is a common ingredient in a lot of facial skincare moisturizers, and it provides hydration and tissue repair without the use of hormones. And then there's also hormonal therapy. So then there's localized estrogen, so topical estrogen that you can use on the vulva or on the vagina, which can, again, help plump up the tissue because the tissue on the vulva and vagina are so sensitive to estrogen. And a lot of times topical hormones are really the only thing that really do help in the severe cases. And these are also in women who have frequent UTIs, sometimes bulking up the tissue down there with topical estrogen can help reduce the risk of UTIs. That is something we see very commonly in women who undergo menopause. And then there are several emerging interventions such as CO2 laser treatments to the vulva and vagina, and the CERM that we discussed on the past slide that help with tissue repair in the vulva. And these are emerging, and menopause care is gaining a lot of traction, and so we anticipate seeing a lot more treatment options going forward. So, I alluded to this on the first slide that I was presenting, that there are several different emotional impacts and challenges with cancer care and with cancer survivorship, and which can be compounded by menopausal symptoms. Cancer diagnosis can cause anxiety, depression, and changes in self-esteem, and menopause can do the same. And so they're often just, kind of tag teaming and can be really hard for younger cancer survivors who are going through both of these. Body image issues can affect every aspect of life and obviously can in fact affect sexual health and thereby affects intimate relationships. And so we need to really be addressing these sexual health issues, because these are kind of central to a lot of the things we do as gynecologic oncologists and people who support people through survivorship. There should be special counseling, support groups, and sexual health specialists that provide care for these women. And then there's also cognitive behavioral therapy, sexual rehab, pelvic floor physical therapy that can help with all of these issues as well and improve quality of life. And again, I know Dr. Frey talked about this as well, but one big reason to be considering treatment of menopausal symptoms is the bone and cardiovascular health. And so, as we discussed before, menopause does increase your risk of osteoporosis. And so earlier menopause increases your risk. This graphic here is in a woman who isn't having premature menopause. It's kind of looking at the average age of menopause, but a lot of our cancer survivors, we're putting people into menopause 20 years or so before the natural age of menopause, which in our country is 51. And so we're kind of moving up this risk of osteoporosis. And so again, like we talked about before, calcium, vitamin D, and weight-bearing exercise have been shown to help with this, as well as if osteoporosis or osteopenia is noted, there's medications that your doctor can give you to manage that. And then other considerations for women in early menopause is the cardiac health. We want to make sure that your primary care doctor or whoever's, kind of managing your heart health is aware of the risks of menopause on heart health and is, looking at your lipid function, making sure they're aware of your cardiovascular risk and kind of altering, not just based on age, but the age at which you went through menopause. And so if we could boil down the three take-home points for this talk is, I would say that one, a personalized treatment approach is necessary. Customized treatments and shared decision-making are essential for managing menopausal symptoms safely. And point number two would be that sexual health, mood, and sleep quality are very, very important for menopause management and for quality of life. And these should all be considered when making these decisions. They're just as valid as all of your other concerns that you may have. And then third point is that gynecologic oncologists, we have data for support of use of hormone replacement therapy for managing menopausal symptoms. And so it's absolutely something to discuss with your oncologist because there's several situations in which hormone replacement is safe and can absolutely help with your symptoms. And so with that, I say thank you, and we can open up to ask any questions. And again, as a reminder, September is Gynecologic Cancer Awareness Month, and the teal ribbon is our ribbon. And thank you for sharing this time with us.
Great. Thank you so much, Dr. Gerber and Dr. Frey. That was a lot of information that you got through, and we do have a lot of questions. So let's get started with the Q&A. Everyone can continue to submit your questions in the Q&A section at the bottom of your screen. We're going to try to get to as many as we can. So we're getting some questions about how long can people expect their menopause symptoms to last? And in particular, this person is asking about whether their hot flashes will ever stop.
So that's a question, yeah, we get often. Everyone is different. Some women can report symptoms for a few months. Some women don't have any symptoms at all.
Mm-hmm.
And then there's some women that can have symptoms up to 10 years. And it's really hard to know who will have long symptoms. A lot of times our menopause symptoms mimic what our mothers had. And so asking your mom, but if your mom tells you it's 10 years and maybe that'll make you lose hope, maybe don't ask. But yeah, it's really, there's no kind of blueprint for how to know how long.
So it's very on an individual to individual basis. Okay, great. And then there were some questions about sort of how BRCA mutation status may or may not factor into this. And then in particular, we got a question about whether the guidelines in the Lancet considered this.
I can talk about that a little bit. I do think there's a common misconception across the country that people with BRCA mutations cannot be on hormone replacement therapy because that will, in addition to then a gynecologic cancer, cause a breast cancer. And unfortunately, even many women who are having preventative surgery for ovarian cancer, so women who are often in their 30s and 40s, don't have a cancer, have their ovaries removed, and many women are not being recommended hormone replacement therapy as part of that preventative surgery. And when I say many, probably more than half of the cases that are happening nationally, people aren't being told they should be on hormones. So I would start by saying if someone does not have a cancer, that is responsive to hormones and they go through early menopause, we should be offering and probably recommending hormone therapy. So like the special case with someone with a BRCA mutation, if they have a breast cancer, that's a different situation and a whole nother talk about what the very individualized, much more nuanced. But for someone who has not had a breast cancer and does not have a gynecologic cancer that's responsive, they certainly should have the option to go on hormone replacement therapy. Now, the progesterone in many of the kind of treatments may slightly increase the risk for breast cancer, but it is slight, and at least this deserves discussion with your treating physician, whether that's your oncologists or your gynecologist or menopause specialist. So just to say this, you can still go on hormones even if you have a higher risk of breast cancer.
Great. Thank you for that. And then we're also getting a question about whether the amount of estrogen or progesterone positivity matter when making this decision.
So theoretically, yes. In gynecologic cancers, we don't usually quantify, we don't consider it as a percent. We're not looking at what percent. We're usually just considering it ER positive, PR positive, in general. But it would make sense that if something's more ER, PR positive, that it could kind of alter treatment, but it's not really used in our algorithms.
The only thing I would add to that gets a little bit confusing is like the uterus, the tissue has estrogen receptors. Like that's how the uterus works. It responds to estrogen. So if you looked at a uterine cancer, you might see estrogen receptors. But we know like in sarcomas of the uterus, you'll see it, but that's not what caused the cancer. And we actually have proof that you could still give estrogen and it will not affect the rate of that cancer coming back. And so I think it can be a little complicated in gynecologic organs, which sort of, it might just be kind of a coincidence that they have these receptors, but they're not going to be, that's not what drove the cancer. That's not what's going to cause the cancer to come back.
Okay, that makes sense. And then someone's asking if there's any quality research that they can review related to endometrial cancer and hormone therapy to help them make a decision.
Yeah, there's one prospective study. So when we think about the quality of research, a lot of the research in cancer care tends to be retrospective. So we're looking back at women who have certain cancers who then we're comparing women who had hormone replacement and who didn't, and then comparing outcomes. So that's good research, but it's not high quality. What we look at is prospective studies. So women who we're kind of controlling the factors and we're kind of randomizing. There isn't such high quality data in endometrial cancer, but there is some prospective data in early stage endometrial cancers that shows that hormone replacement is safe. It's from 2006, I believe. I can send, if someone wants to tell me, I can send them the paper.
Yeah, if you send it to me, we could distribute that. Great, thank you. And then I know you talked about different like lubricants and moisturizer, but wondering if you could address a little bit more about desire and libido.
So this is a complex topic that I could spend an entire hour talking about as well. So female sexual arousal is a complex process. It is affected by hormones. It's affected by menopause for sure. But it's also affected by body image, by psychological, well-being. It's affected by, like so many psychosocial factors. And so unfortunately for female like hyposexual arousal syndromes, there's really not a one clear way to treat that. There is some off-label use of testosterone for like low sexual desire in women. That is again, the data is kind of mixed, but it is being used off-label very commonly. And from what I've heard from my patients, it does work.
Mhm.
But again, it's so complex, and there's
Mhm.
unfortunately not one thing to do.
Mhm. Thank you. And then a couple of questions related to like how long people can be on hormone replacement therapy, and then also at what age would someone maybe consider stop using it?
So the general kind of dogma on this
Mhm.
is that so in our country, the natural age of menopause is early 50s,
Mhm.
50, 51. And so we've always been taught to keep women on hormone replacement until the natural age of menopause. And that has been always a consideration. There's also a kind of emerging data on, does menopause ever even have to happen? Why do we need to stop people at 51? And that is something that is, there are providers and there are patients who stay on them forever because they don't want to have the symptoms of menopause. And so it's a very personalized decision. But in general, I think if we were to give a textbook answer to this, it would be until the natural age of menopause. But that, again, a very personalized decision.
And like what I usually tell people is like when you approach 50 to 51, which is the natural age, we would consider coming off of it, or even in the couple years preceding that, you might like taper down the dose, like would happen in a natural menopause. But there is no absolute rule as to when it has to end. And if you are very symptomatic, that is like a shared decision between every individual and their doctor.
Mhm. Great, thank you. And then this person is asking if there's any benefit to like decreasing the risk of dementia for with taking hormone replacement therapy.
So the dementia risk is not so well established yet. We do know that there's increased risk of a lot of brain fog, dementia-like
Mhm.
symptoms, Parkinson's, likely Alzheimer's. And so that's not an indication to put people on hormone replacement, but it probably would help, but we don't have like strong guidelines on that at this time.
Mhm.
And I would say this is my plea, like, we need to find people who want to work on this. And I think there is like just a paucity of research on anything related to like women's health and brain health and dementia.
Mhm.
And like we need to get better at this and we need neurologists working with oncologists. So hopefully
Mhm.
that will change because we just don't know.
Mhm. And then, could you talk a little bit more about some lifestyle remedies that could address things like insomnia? So this person is saying, like, for example, waking up in the middle of the night and waking up early, things like that.
So I talked a little bit about sleep hygiene,
Hmm.
making sure that you're avoiding caffeine, making sure you're not drinking too many fluids before bedtime so that you're not waking up to go to the bathroom. That's a big one. Making sure that you're in a calm, restful state, that the temperature of your room is really cool. Oftentimes I'll recommend like bed cooling. There's like things you can put under the mattress, or not under the mattress, under the sheets that can help cool the bed, which can lead to a more restful, cool sleep. Um, those are some main ones, but melatonin can help with sleep. But again, it depends on what the cause of insomnia is, because insomnia, like you know, other things we talked about, is not just one thing. It can be caused by anxiety, but it can also be caused by depression. It can also be caused by frequent urination. There's so many different reasons, and figuring out what the cause of your insomnia is and addressing that symptom.
Hmm. And then another symptom that I know you sort of briefly touched on was the hair and skin changes. So we did get a question about any like suggestions for dealing with the dry skin, especially.
I'm not so um aware of if there's like special, moisturizers. I would recommend frequent moisturization. There is some new data on use of estrogen containing moisturizers that has been shown to kind of improve skin elasticity in low quality studies. But I actually think this is going to be in the coming years, this is going to be something that will be used more. And again, when we use topical estrogen, some of it is absorbed systemically, but it's not absorbed systemically in the same way that you would see all the other risks of hormone replacement. And dermatologists, it depends on what the skin issue as well. So, lasers, Botox, all these things can be considered, but I'm not promoting those things. It's just based on the symptom and how it affects you personally.
Great, thank you. And it looks like I'm just going to try to squeeze in one last question, but just do people who are on this have to have like greater surveillance, or is it the same?
Hormone replacement in terms
Yeah,
of
hormone.
their
Yeah.
cancer surveillance, I don't do anything differently. It depends on what phase of cancer survivorship they're in, but for the most part, I'm seeing patients. I'm sure Dr. Frey is similar. We're seeing patients every 3 to 6 months in the beginning, and doing whatever blood work is indicated in that regard. And I'm not doing really anything differently. Not doing scans more. I'm just having people come in for exams on a regular basis and having them really kind of let us know if their symptoms change so we can kind of manage it as needed.
And the only thing I would add to that is for some of these medications like Veoza, you might want to check the liver function tests. If people are using testosterone, we usually do some pre-tests. And then if people are on hormone replacement therapy, I usually do just kind of check in with them, when I see them about it, to remind them, this does increase the risk for blood clots. And so if you're on a very long flight, or if you have a major fracture, just check in with me or think about stopping, or just, sort of general counseling, because often other doctors won't mention this as part of their regular exam.
Great. Thank you so much, Dr. Frey and Dr. Gerber. We were able to get through a fair amount of questions, and we really appreciate your time and expertise and thoughtful answers today. And thank you to every single person who joined this webinar.
Thanks so much, everyone.
And so just a few quick reminders before we close. As we mentioned, the webinar is being recorded and streamed to YouTube Live. The link to the recording will be available right after the webinar on Share's YouTube channel. Be sure to visit Share's website to check out upcoming educational programs, podcast episodes, and support groups. You can also stay connected by following us on social media for the latest updates and resources. We truly value your feedback, so please take the anonymous survey that will appear in your browser when the webinar ends, and you'll also receive it by email afterwards. Your input helps us shape future programs to meet your needs. And again, on behalf of all of us at Share, thank you so much for joining today. And thank you again.
Bye. Thank you.